Hello everyone, my name is Salari. I'm a PhD student in computer science at Concordia University. I'm presenting our paper titled towards multimodal anatomical landmark detection for ultrasound-guided brain tumor resection with contrastive learning. Anatomical landmarks are specific points in medical images that doctors and surgeons are interested in. Actually, they are critical tools for medical image registration and validation of the medical image alignment. However, they are still annotated manually, which is a highly time-consuming and expensive task. In this regard, deep learning models can help to automatically detect landmarks in medical scans. In the context of single contrast landmark detection, we usually have consistent locations across subjects, a fixed number of points for the landmarks, and similar image orientations and views. On the right, you can see some single contrast landmark detection results from deep learning models. MRI ultrasound landmark pairs are beneficial for validating the image registration algorithms for brain shift correction in ultrasound-guided brain tumor resection. However, there are unique challenges in finding MRI ultrasound landmark pairs. First, there is a large disparity in image contrast between MRI and ultrasound. Second, image orientation and the content vary across the subjects. Also, landmark locations vary despite the consistent protocol for landmark tagging in ultrasound and MRI. Finally, there is limited public data for these tasks. Contrastive learning is a technique that tries to maximize the similarity between the positive pairs while minimizing the similarity for the negative pair. In this context, we have anchor positive and negative, where we want to maximize the similarity of the anchor and positive and minimize the similarity of the anchor and negative. It's also an effective strategy for image feature learning for smaller samples. Here you can see the proposed framework for MRI ultrasound landmark detection. In this framework, we use the 2.5D image patching approach to reduce the computational complexity. We first extract the reference and query patches from the MRI and ultrasound using the 2.5D approach and forward them to the CNN models to extract the features, calculating the loss and training the model. During the inference, we use the cosine similarity to match the most similar ultrasound patches to the reference MRI patch, and finally find the landmark. We developed and evaluated our model based on the ReSeq database. We also compared our method results with the 3D Shift algorithm results for landmark matching. We got the absolute error of the 18.78 plus minus 4.77 millimeter for the 3D Shift and 5.88 plus minus 4.79 for our proposed method. Our proposed method could outperform, as you can see in the table, could outperform the 3D Shift approach with a statistical significance. We also noticed that the magnitude of our method's error can be affected by the level of the brain shift. In conclusion, our method is the first contrastive learning approach for the intermodal landmark matching. Our method achieved the state-of-the-art results for MRI ultrasound landmark detection and made the first step towards the efficient and accurate intermodal landmark identification that has the potential to allow intraoperative assessment of registration quality. We acknowledge the funding resources, Concordia University, NSERC, and FRQNT. Thank you very much for your attention.